how HIV attacking our immune system phase by phase, like it attached to host cell, then viral copies, then integrated to host DNA, then replicates, and it multiplies in it like its population. A very good afternoon to all respected seniors and other my colleagues, all coming from all states. Today I would like to take this opportunity to present which is my topic, HIV treatment and care. So current trends and best practices. So a few incidents, few lines about incidents. So globally 39.9 million were living with HIV at the end of 23. So but the bottom line is like HIV incidence since 2010 has been reduced by 39%. And then few statistics. I will quickly go through the statistics. So here we can observe people living with HIV compared to 2018-19. So this is the structure of HIV virus. For like any virus, it's a core, core with some RNA strand. Then there are two types of HIV viruses. So as everyone knows, HIV is the most common virus, but we should also know about HIV 2 because like both treatment line varies from HIV 1 to HIV 2. Then AIDS is the like severe manifestation of HIV virus, but it can be prevented. So these are the modes of transmission. What are the various routes of like unprotected sex, like injectable drugs, blood transfusion are the most common ways of transmission of HIV. And this is a misconception about touching, sharing cutlery, kissing, insect beds, but these are not the actual routes of transmission. And this is the most modes of transmission HIV in children because it is most important. We should try our best to cut off the transmission in children so that their quality of life will be good. So this is the most common routes of like transmission with the percentage of risk here mentioned, where blood transfusion is the highest mode risk. Then window period. What is that significance in window period? Because some like persons test false negative during this time actually. So they still pass the virus to others during this period. Then how it infects the body? It carries to regional lymph nodes, replicates, multiply rapidly, and spreads to the other vital organs like brain, spleen, distant lymph nodes in 5 to 11 days. And so what is that our importance of immunity while fighting against the HIV virus? These are the super soldier, we can say, helper T cells. So these are like very, our CD4 cells are super soldiers. They act like a super soldier in fighting with HIV virus. This is the brief diagram of how HIV attacking our immune system phase by phase, like it attached to host cell, then viral copies, then integrated to host DNA, then replicates, and it multiplies in it like its population. So this is the untreated stage, untreated HIV infection, the stages. So viral transmission followed by acute retroviral syndrome which lasts for 2 to 3 weeks, then seroconversion in 20 weeks, then asymptomatic HIV infection may last like up to 8 years, then symptomatic HIV if we don't treat timely. These are the common symptoms of HIV infection. For any like viral fever, some flu-like symptoms maybe patient may experience. Here like depicted in organ-wise, system-wise diagram. Then this is how these antibodies, the number of antibodies and number of virus replicates. We can see this flow chart. So we can be also smarter while virus is smart. So with healthy practices, with good nutrition, with timely appropriate ART, we can make our soldiers more stronger. So from these available investigations, per se HIV rapid test, ELISA, Western blot, antigen test, per se PCR or viral load, P24 antigen, we can diagnose the infection. So coming to treatment part. So counseling comes first before proper treatment because it should be lifelong. Frequent monitoring may be essential. So we should counsel about the cost implication, pill burden, adherence, dose compliance, so social implications, pre-exposure prophylaxis importance. These are the comes under the counseling part. Then coming to proper ART. So ART was program was launched in first in like 2004. Thereby like every year, every phase, there are like new amendments are coming in the treatment line. So the overall goal is to improve the survival and quality of life patient living with PLHIV. So it helps to achieve maximal, most durable suppression of viral replication. So we can prevent the emergence of drug resistant mutants by giving appropriate ART. So when to start? There is like there is no like time. So we should test and treat policy. Now it's going on. So regardless of CD4 count, regardless of clinical stage, age, population, we should treat immediately. Then why it should be lifelong? Because some viruses go into resting mode and escape from ART, they can get activated when needed. So ART should be lifelong. Then coming to very few lines about NACP, just I will quickly go through 1, 2, 3, 4. And now so if is phase 2, so these are importance is like ICTC, PPTs and all launched and established during that phase 2 only. Then coming to 2007 to 12-3, there is a importance of like establishment of DAP2, that is like district AIDS prevention control units, and the importance of 4 is 2012 to 17. There is a launch of National HIV Helpline. Then coming to, this is the 4th extension phase, 17 to 21. So acts and mission Sampark and DSDM, differentiated services, these are all the important events which occurred in NACP phase 4 extension. Now like 2017 to 21, this is the brief chart of evolution of the NACP programs. Now we are in like phase 5, which is 2021 to 26. These are the goals. Reduce the annual infection by 80% and mortalities also, eliminate vertical transmission, promote universal access to quality, eliminate HIV related stigma and discrimination is the goals of the current phase of NACP. So coming to proper treatment, this should be our goal, ART, HIV medicine. So we can stop every step of the HIV transmission by giving appropriate category of medicines. Like we can next slide I will explaining. So these are the class of different ARV drugs: nucleoside reverse inhibitors, non-nucleoside protease, and entry integrase. So these are the commonly used drugs. Currently we are using these drugs under ARV antiretroviral treatment. So zidovudine, lamivudine, emcitrabine, stavudine, abacavir, tenofovir are the nucleoside. While coming to non-nucleoside, nevirapine, efavirenz. These are the protease: ritonavir, lopinavir, atazanavir, darunavir. Integrase: raltegravir, elvitegravir, dolutegravir, bictegravir. And entry inhibitors are enfilutamide, maraviroc, ibralizumab. So mechanism of action of the drugs is like particular blocking of that etiopathogenesis will give the output of the result. So coming to regimen of first line. So tenofovir, lamivudine, dolutegravir 50 mg is a fixed drug combination like we are using single pill once a day. So a single TLD preferably taken at bedtime. Okay. patient with severe diabetes, hypertension should be monitored because like for the TDF, tenofovir toxicity. And one more important point to be remembered is patient is who are taking on DTG should be monitored for blood glucose because for weight gain chances and diabetes chances. So appropriate physical activity should also advised. Then this is the regimen in children. So after confirming HIV infection, so if the child is below 6 years, the body weight less than 20 kg, abacavirin, lamivudine, lopinavir. If the age is 6 to 10, weighing body weight is like 20 to 30, we can put on abacavir, lamivudine, dolutegravir. Then if age is more than 10 years and body weight more than 30 kilogram, TLD we can give straightly. So now this is the which I am telling. So second line, alternative first line, we can put on tenofovir, lamivudine, efavirenz 400 mg instead of DTG, where it is contraindicated. Then these are the monitoring flow chart. Different. See, if it is patient is on TDF based regimen, we should timely, periodically we should check for serum creatinine. If patient is AGT based regimen, hemoglobin we should check. So nevirapine based ALT, AFB based regimen lipid profile, and ATV based regimen LFT, proton inhibitors based regimen blood sugar lipid profile. So every CD4 count and follow up every 6 months repeatedly we should follow. Then if the patient failed on treatment, first line treatment, so first we should confirm the treatment failure before going to second and third line regimen. So treatment, we should check like treatment adherence is there or not, drug interaction are there or not, certain opportunistic infection or malignancies are there. So unless until we prove the failure, we can't switch to other regimen. This is the formulation of second line drugs where the first line failures. So these are the second line. If the failing first line regimen, recommended regimen is tenofovir, lamivudine, efavirenz or nevirapine, and the AGT plus lamivudine, nevirapine. So multi-NRAT exposed lamivudine, efavirenz, we have to put on ritonavir boosted attenavir, DTG and existing NRAT backbone. So these are the recommended ART regimen for patient failed to first line containing dolutegravir. Dolutegravir based regimen if we fail, so we should assess hemoglobin first. If the hemoglobin is more than 9 grams, we can add ritonavir boosted attenavir. If more than like this thing, BD dose should be given, DTG. And then coming to other regimen, without tenofovir, we should add ritonavir boosted attenavir and use in case of pregnant women or HIV2, we should implicate lopinavir, ritonavir boosted lopinavir. These are the NNRT based regimens. If it fails on treatment, we can accordingly put this regimen. So third line also, but third line we should keep in mind few points before prescribing third line, because it should include new drugs, it should be there should be minimal risk, and third line formulation will be found by integrase inhibitor and new protease inhibitors. So third line usually we put dolutegravir 50 mg ORI plus darunavir 600 mg BD and ritonavir 100 mg BD, usual combination. So there may be many scenario depicted in this flow chart. What are the different scenario? What are the different drugs can be introduced? Coming to current trends and best practices for HIV. So these are the practices: universal test and treat, and ART should be lifelong, and viral load monitoring, pre-exposure prophylaxis, HIV self-testing, integrated care should be there, and insist the partners also get tested, treated too. So and using medicine to treat and prevent HIV using by condoms, having only low risk sex, and abstinence also one of the best practices to prevent the HIV. and community engagement, data-driven decision making, addressing social determinants, innovative technologies these are the best practice in HIV treatment. Global AIDS strategy is a bold new approach to use an intellectualist lenses to close the gaps of the preventing progress towards ending AIDS. And the new treatment for HIV, lenacapavir, is being developed as a foundation for potential future HIV therapies, offer both long-acting oral and injectable options with several dosing frequencies in combination as a as a mono agent. So these are the rationale of public-private collaboration. These days, NACP is like collaborating with private practitioners for like better action towards elimination of HIV. And what else like new? So HIV self-testing kits are the new in HIV treatment, and daily pre-exposure prophylaxis like appropriate for some high-risk groups, and evidence-driven pre-exposure prophylaxis also there. So some updates are last is like vaccines. Few points about vaccine. What is the need? Because despite the remarkable achievement, development antiretroviral therapy, there is like definitely need for HIV vaccine. But challenges in the developing vaccine are like HIV mutates rapidly, and it mutates in one day as much as flu virus do in a year. So the virus has developed multiple mechanisms to evade the body's defense and targets very like CD4 cells and coordinate immune response to viral infection. These are the challenges. But few trials have been like encountered, but some are ended with some any like new other progresses. These are the few examples which I have collected. AIDS vax, and this Ohambo HVTN 702, which is conducted in South Africa, and this is Imbokodo HVTN 705, and Mosaico HVTN 706, conducted in many other countries. So these are the few updates about vaccines, and what is the like near future. So long-acting formulations like injectable implants, so much less frequent dosing to simplify disease management are the near future perspectives. So thank you.
Thank you, Dr. Vijay Kumar. You have covered a vast topic within a short time.
First time actually I'm writing, sir.
But one and two things I want to express. As a sexual medicine specialist, people will ask, can we get a child for us? That is a discordant couple, concordant couple. So you want it. Yes, that is an important thing.
Yeah, sure.
You want to answer?
Yes, sir, definitely. That is the motto of our like HIV programs and all these NACP 5. These are all that will be the prime motto of these programs. So definitely, appropriate treatment, like timely treatment, will definitely helping in like HIV negative child.
Yes, that is pre-exposure prophylaxis for the discordant couple. And one thing, another thing is on ART, the patient is regular on ART. Within 48 weeks, the patient will have undetectable viral load. So with the undetectable viral load, he is no longer infectious to his partner, either for horizontal transmission or vertical transmission. He is now they are saying they can be allowed to have without any, and there is unprotected sex. So that is also at the time of fetal period, they can be allowed to have sex. And also we are having so many IVF procedures. That is one thing. Another important thing about sexual medicine practitioner and AIDS is many patients have sexual dysfunction, because one is advanced HIV, another is fear of transmission to the individual, and fear of death, so many things. One more thing is HIV phobia. So among these, if I see 10 cases of STI, 3 cases will be phobia cases. I have touched this, I have touched this, can I marry, can I kiss my wife, can I have sex, can I resume sex? So many things will there. So we will be able to answer all these things. If you knew all these things, how it is transmitted, just by touching and other things, people will ask, I have entered that bathroom and I touched the knob. Previously, some people who have used, he may be HIV positive. Shall I get the infection? So many things will be asked. Because of that, they will afraid of getting married. They will afraid of mating with their wife. Afraid of so many things. They will not touch their children. So many things are there. So that will be more interested. So we must be knowing about this HIV status. Then only we can tackle these patients successfully. Thank you.
Thanks.
I'd like to add one thing. When you do the counseling, three things we should remember always. First thing, our colleagues regarding. We doctors, medical practitioners have so much reservations about the HIV. Oh, he's HIV patient, why should I treat? You should send it to someone, it's not my cup of tea. So we ignore these patients. So we should not ignore that thing. Second thing, person who is HIV, we should counsel him and tell him it is like diabetes. What will happen? Diabetes, once you have, it will be lifelong, we will get diabetes. But with medicines, you can control the diabetes, you can live normal life. Same way, HIV, if once is positive, that does not mean the end of his life. Only thing he need to evaluate on timely, take the medicine properly. As you said, you would need to take nutritional food and everything. And third things, the relatives. HIV, when HIV, someone is diagnosed with HIV, so his spouse, his or her spouse or family members, they ignore him like ये अछूत हो गया है, उसको हम हाथ नहीं लगा सकते. तो you should always tell them, these people, कि स्पर्श करने से is working.
Working, sir.
Working. Let me. So relatives को आपको क्या कहना है कि स्पर्श करने से सिर्फ प्यार बढ़ता है, मोहब्बत बढ़ती है, HIV नहीं फैलता है. स्पर्श से सिर्फ जब आप दूसरी चीजें करते हैं तब HIV फैलता है. बाकी स्पर्श करने से, जैसे साहब ने बोला मुरुगन सर ने कि भाई नॉब को टच कर लिया, ये सबसे तो सिर्फ मोहब्बतें पड़ती है. स्पर्श करने से कभी HIV नहीं फैलता है.
If both are HIV positive, husband and wife, then what advice or counseling you will do?
If both are HIV, see, when HIV is there, only not HIV infection is important, the viral load is very important things. So if both are HIV positive, that does not mean that unko koi precaution nahi leni hai. Because they, if do unprotected sex, they will be having the viral load will be increased them for them. So they should always use the barrier protection, should be used. Baki jo normal things hoti hai, कि you should not use same brush and all other things jo baki hoti hai, that's, they should do the things.
They were, from fertility point of view, they were asking.
Fertility, they already said IVF you can do when she is pregnant. Instead of normal deliveries, they should go for the C-sections and all these things. They should do it.
So that is possible, sir, as I said.
Breastfeeding, I was asking Dr. Murugan sir, because most of the time we say that the females, the milks, that is having more immunity and all other things. But in his slide, he said that breastfeeding, it can be spread. So I asked Murugan sir whether it's true or not. So he said, I'll discuss this thing.
So, sir, my question is, I'm surgeon. Basically, we have to operate positive HIV positive patient, and sometime may prick, needle prick. So, what are the chances of infection, and how we can prevent, what medicine we have to give, and how much time we have to give, and when is it started?
Same, sir. Like post-exposure prophylaxis you are asking, sir. So simply like TLD will be given for 28 days cycle.
For 28 days. And when we start?
Like it's ideally it should be taken within 48 hours.
Within 48
72 hours.
72 hours as early as possible.
As early as possible.
Not
And
after
how much?
Not after 72 hours.
And how much is chances of infection?
See,
That depends upon the exposure, needle
see
prick.
depth of
I'm
the,
talking about especially needle prick.
sir, depth of
I'm
like,
a surgeon, so we have to operate HIV positive patient also.
sir, definitely it can be like it can be prevented by within like 2 days if you are taking that is TLD, you won't be like acquiring the infection for 100%.
I'm saying
No chance. Ante,
how much percentage
not
of chances
taken.
in a
It depends on
single
the
needle prick
penetration,
are
that length and everything.
Sir, there is not
The
a
discharge.
single studies which says that by only pricking the person
Source.
got HIV positive
What
or
is the
something.
source?
So percentage wise, it's very difficult to say. Like we say, oral sex can also lead to the HIV because
no
if
sir,
some
it is a documented. It is 0.02% chances of month means it is a 2,000 times.
Source of like
2,000% leak in
infection
one,
also.
chances of one.
Source of infection also plays more important.
Because of the constraint of time, we will restrict, we will discuss later.
Okay.
Regarding the breast milk also, if anybody wants, I will tell later. Thank you.
Thank you,
can-
Dr. Vijay. Please, Dr. Vijay, please. say
Varun,
back.
just 2 minutes you tell about the breastfeeding. 2 minutes superficially.
Okay, so the the transmission of breastfeed through breastfeeding is possible only 15%. That too for a longer time, not a single time. So that is thing. So why we are allowing in our country the risk of substitute feeding is more than the breastfeeding because of their handling the diarrheal disease and other disease. Because of that, so the people are not trained for that. So we are in our country, we prefer to have breastfeeding instead of substitute feeding, whereas in Western countries they are totally banned as breastfeeding, only supporting the breastfeeding. The breastfeeding, another thing is we should do 6 months exclusive breastfeeding, not a combined. One time breastfeeding, one time bottle feeding, it should be, because the bottle feed may likely to induce a gastritis which enhances the chances of transmission fastly. So the alternate feeding should not be there. Exclusive breastfeeding, not even water. So that has to be continued for 6 months as per our guidelines is telling. Western guidelines, exclusive substitute feeding only.
Thank you, sir. So I request Dr. Ajayan sir to kindly felicitate Dr. Vijay. Please bring the memento, and please Dr. Murugan and Dr. Paras sir, please join.